Welcome to This Explainer. Okay, we're going to dive right in and put you in the hot seat today. Imagine you're on the pediatric floor and you're suddenly faced with a high-stakes clinical scenario. You've got to know what to prioritize, you need to spot those safety alerts instantly, and you have to know exactly how to dodge those classic test traps. Today, we're taking the source materials and breaking down pediatric sensory and cognitive disorders into really clear visual anchors. By the end of this, you're going to be able to spot those traps from a mile away and deliver perfectly prioritized patient care. So, picture this scenario. A child with otitis media, a middle ear infection, has been crying inconsolably because they're in severe ear pain. But then, they just suddenly stop. They seem completely relieved. Pause and think about that for a second. What's going on here, and what is your very first priority? This right here is a classic top-tier test trap. Because honestly, it's super tempting to just celebrate that the pain is gone, right? But this sudden shift is actually a major red flag.
Let's unpack that in Section 1, Sensory Priorities for the Eyes and Ears. Okay, starting with otitis media. The source material outlines some really clear manifestations. We're talking sudden ear inflammation, fever, irritability, and those classic behavioral cues like ear tugging, head shaking, and dizziness. You might even see some yellow or green otorrhea, which is just ear discharge. But here is your clinical safety stop. If your patient suddenly feels relief from that intense ear pain, or if you unexpectedly see bloody discharge, the guide points directly to a tympanic membrane perforation. Basically, the pressure inside the ear built up so much that the eardrum just ruptured. That rupture releases the pressure, which stops the pain. Now, the good news here is that these perforations actually often heal spontaneously without us having to intervene. But recognizing that sudden relief equals a rupture, that is an absolute must-know detail. Now, a really crucial point here is understanding how conditions like otitis media actually impact a child's long-term development. Let's chunk hearing loss into 3 easy categories based on the data. First, conductive hearing loss. This is caused by blockages or malfunctions in the outer or middle ear, which is exactly where otitis media happens. Then you have sensory neural hearing loss, which occurs way deeper in the inner ear, the cochlea, or the auditory nerve. And mixed is, well, just a combination of the two. So why does this matter so much for your pediatric patient? Because chronic conductive hearing loss from recurrent ear infections can severely delay speech development. Think about it. If a baby can't hear properly during those formative months, they literally can't mimic sounds to learn how to speak. So early intervention is absolutely critical. Moving on to the eyes, let's build some visual memory anchors for eye disorders. When you hear the word strabismus, you want to instantly visualize eye misalignment. Check out the specific differences. Esotropia is when the eye turns inward. Exotropia is when it turns outward. Hypertropia points up, and hypotropia points down. You really want to burn these prefixes into your memory. That way, when you get a case study describing a child whose right eye drifts outward when they're tired, you'll instantly lock in on exotropia. And real quick, let's clarify another vision concept from the notes just to make sure there's zero confusion on test day. Blindness is not always an all-or-nothing situation. Partial blindness means there is a significant restriction of vision, sure, but it isn't completely absent. Complete blindness, on the other hand, is a total lack of vision. The individual cannot even perceive light or images. Knowing this exact distinction is going to help you tailor your nursing interventions for things like patient safety and room orientation. All right, let's shift gears to Section 2, Cognitive and Neuro Must-Knows. First up in this section is lead poisoning. Lead is a non-biodegradable element, and it causes some pretty widespread tissue damage. Keep in mind, it absorbs far more through ingestion than it ever does through the skin. If we follow the timeline, the absolute highest risk group is children under 6 years old, especially those living in homes built before 1978. Those older homes often have lead plumbing and peeling lead paint. And because toddlers explore literally everything with their mouths, ingestion is the massive environmental trap here. The manifestations you'll see include developmental delays, irritability, GI issues, and slower growth. But here's the specific lab trap you need to watch out for: low iron, zinc, and calcium levels. Lead actively competes with these essential minerals in the body. Next, we have ADHD, or Attention Deficit Hyperactivity Disorder. The data shows that manifestations usually show up before 12 years of age, and we can easily chunk them into 3 main buckets. There's inattentive. These are the kids who are easily distracted, they lose things, and they struggle to follow instructions. Then there's hyperactive. These kids are impulsive, restless, fidgety, and they tend to interrupt a lot. And finally, combined, which is exactly what it sounds like. When it comes to treatment, the source points us to a targeted trifecta: behavioral therapy, educational support, and medication. Now let's trace the timeline for autism spectrum disorder. ASD is a neurodevelopmental disorder, and it typically presents right within those first 3 years of life. The core manifestations generally fall into two main categories: social and speech impairments, and repetitive or restrictive behaviors. In those early years, you are going to see a very literal outlook on language, unnatural speech patterns, avoidance of eye contact, and a lot of difficulty reading body language. They might also be super sensitive to loud sounds, fixate heavily on specific topics, and struggle a lot with adjusting to even minor changes in their routine. Safety stop. Listen closely, because we need to drill down on the priority action for patient with autism. The absolute highest priority here is keeping that child safe. These patients are at a severe risk for elopement, which basically means wandering or running away from safe environments. They might also exhibit headbanging, aggressive behaviors, or self-harm, especially when they feel overwhelmed or overstimulated. Your job is to heavily monitor their environment, actively reduce sensory overload, and maintain really strict safety precautions.
Let's get into some pattern recognition for genetic conditions, starting with Down syndrome. When you're reading a clinical prompt, you want to visualize these physical manifestations so they just jump off the page. Build a memory trick in your mind: almond-shaped eyes that slant upward, a short neck, small ears, and a protruding tongue. You might also notice small white spots on the colored portion of the eye. Look at the extremities too: small hands and feet, a single palmar crease straight across the hand, little fingers that bend toward the thumb, and an overall poor muscle tone with really loose joints. Grouping all of these into one visual anchor is going to guarantee you instantly spot a Down syndrome scenario.
Now, we want to contrast that with Fragile X syndrome. This is noted as the most common developmental and intellectual disability in children, and it's caused by a mutation of the FMR1 gene. Now, unlike Down syndrome, where those physical traits are super obvious right at birth, the physical manifestations of Fragile X actually become a lot more apparent during and after puberty. What you're looking for is a narrow face with a prominent forehead, a large head and ears, macroorchidism, which is enlarged testicles, joint laxity, and flat feet. On the cognitive side, you'll start seeing language delays and sensory processing difficulties pop up in younger childhood. Our final neurocondition today is Chiari malformation. This happens when brain tissue is physically pushed down through the opening at the base of the skull, right into the spinal canal. Obviously, this puts immense pressure on the brain and the spinal cord, and it disrupts the flow of cerebrospinal fluid. Symptoms include severe headaches, balance problems, and numbness or tingling in the arms. But pause and really think about this. Look at those final priority symptoms: trouble swallowing, trouble speaking, and breathing issues. When a Chiari patient presents with these specific symptoms, your priority alarm bells should literally be ringing. Airway, airway, airway. Okay, let's bring it all together. Section 3, mini NCLEX clinical scenario and rapid recap. Check out this scenario from the guide. A child previously diagnosed with Fragile X syndrome comes into the clinic with a fever, irritability, and they're constantly tugging at their ear. Based on pattern recognition, what specific comorbidity should you suspect? Give yourself a second. Yep, it's otitis media. Recurrent otitis media and sinusitis are major comorbidities for kids with Fragile X. Let's rapid fire this recap to lock it all in. Number 1, if a crying child with a middle ear infection suddenly stops crying and feels total relief from their pain, do not celebrate. Suspect a tympanic membrane perforation. Number 2, connect the dots between the ear and development. Chronic conductive hearing loss from outer and middle ear blockages like otitis media is a huge culprit for delayed speech development. Number 3, the environmental lead trap. Lead poisoning risk peaks in children under 6 years old. They usually get it by ingesting peeling paint or contaminated water in homes built before 1978. And remember to watch those iron, zinc, and calcium levels. Number 4, the absolute ultimate priority for a child with autism spectrum disorder is safety. You have to strictly monitor their environment to prevent self-harm and elopement. And finally, number 5, for Chiari malformation, because that brain tissue is pressing down into the spinal canal, your number 1 priority alert is monitoring the airway due to associated trouble swallowing and breathing issues. Wow, we have just chunked, visualized, and conquered some of the absolute trickiest sensory and cognitive conditions you'll see on the pediatric floor. Armed with these visual anchors and priority safety alerts, dodging those test traps is going to feel so much more manageable. So as you keep pushing through your studies and building up that clinical judgment, ask yourself, What high-stakes topic are you going to master next? Keep that incredible momentum going, and I'll see you in the next explainer.